Late August 1945. The air inside the damaged clinic is thick and still. Sunlight slips through shattered windows, catching dust as it hangs above rows of makeshift beds. Some are wooden cots. Others are nothing more than doors pulled from their hinges and laid flat. Bandages, reused, washed thin, wrap burned arms and blistered faces. The smell of antiseptic mixes with smoke that still drifts in from the ruined city outside. Japan has surrendered. But here, the war has not ended. Footsteps echo in the corridor. Heavy, measured, leather soles unfamiliar to this place. Japanese civilians tense as one. Some turn their faces to the wall. Others pull blankets higher, as if cloth could shield them from what they have been taught to expect. American soldiers appear in the doorway. Helmets, medical bags, white armbands marked with a red cross. No weapons are raised. No orders are shouted. Instead, a U.S. Army doctor kneels beside the nearest patient. He sets his bag down carefully. His voice is calm, translated softly by an interpreter standing just behind him. The doctor reaches for a wounded arm, burned weeks ago, never properly treated. The patient flinches. Then the doctor begins to work. And in that quiet, uncertain moment, something deeply unexpected begins to unfold. One that will ripple far beyond this room, into the memory of a defeated nation. By the summer of 1945, Japan was a nation physically shattered and medically exhausted. For months, American B-29 bombers had flown almost unchallenged over the home islands. Night after night, cities burned. Tokyo, Yokohama, Osaka, Kobe. The firebombing campaign, particularly the March 9th to 10th raid on Tokyo, had turned dense urban neighborhoods into fields of ash. Wooden homes collapsed in waves of flame. Hospitals were destroyed or overwhelmed. Doctors worked without anesthesia, without antibiotics, without electricity. By August, the healthcare system had effectively collapsed. Then came Hiroshima. August 6th, 1945. In seconds, tens of thousands are killed outright. Those who survived staggered into a medical vacuum. Hospitals lay flattened. Medical staff were dead or injured. Burns covered entire bodies. Hair fell out in clumps. Bleeding appeared without wounds. No one yet understood radiation sickness, but it spread through the survivors with quiet inevitability. 3 days later, Nagasaki followed. Japan's surrender on August 15th did not end the suffering. It exposed it. Across the country, millions of civilians were injured, malnourished, displaced, or sick. Tuberculosis, dysentery, typhoid, and cholera threatened to erupt into epidemics. Food shortages were severe. Children fainted in the streets. Elderly civilians died silently in damaged homes. Medical supplies were almost non-existent. Many doctors had been drafted into military service and never returned. Yet alongside physical devastation existed something less visible, but just as powerful: fear. For years, Japanese civilians have been immersed in wartime propaganda that portrayed Americans as brutal, merciless, and inhuman. Stories circulated of torture, execution, and deliberate cruelty. Mothers whispered warnings to children. Elders spoke of dishonor worse than death. As defeat became unavoidable, rumors spread that occupation would bring violence, revenge, and humiliation. When Emperor Hirohito announced surrender over the radio, many civilians wept, not only from loss, but from terror of what would follow. American troops were expected to arrive soon, and when they did, civilians prepared themselves for the worst. They hid valuables. They kept daughters indoors. Some families prepared poison or knives, convinced that survival under occupation would be impossible. The wounds of war were still open, and now the enemy was coming in person. What few civilians understood was that the United States was preparing for occupation with a different priority than conquest. The war had revealed a hard lesson to Allied planners. Disease could destabilize victory faster than resistance. A starving, sick population could not be governed. Epidemics did not respect surrender lines. If Japan collapsed into chaos, occupation itself could fail. As a result, medical planning became a central pillar of post-war strategy. Even before American forces landed, the U.S. Army Medical Corps and Navy Medical Services were mobilizing. Field hospitals were prepared not for combat, but for civilian care. Shiploads of medical supplies, penicillin, sulfa drugs, surgical equipment, vaccines, were staged for deployment. Preventing mass disease outbreaks became as important as maintaining order. This marked a fundamental shift in the role American doctors were about to play. They were trained to treat soldiers wounded by gunfire, shrapnel, and blast. Now, they would face burns weeks old, radiation injuries no textbook yet explained, children wasted by hunger, and civilians who flinched at the sight of their uniforms. The occupation would officially begin in early September, but the medical crisis was already waiting. And when American doctors finally stepped into Japanese hospitals and clinics, they entered not as conquerors, but as strangers walking into a landscape of fear, ruin, and silent expectation shaped by years of war. That tension between what Japanese civilians feared and what American doctors were ordered to do would define the first fragile encounters of occupation. On August 28, 1945, the first American advance elements arrived in Japan. Within days, the full machinery of occupation followed. General Douglas MacArthur was appointed Supreme Commander for the Allied Powers, SCAP, and with that authority came an unprecedented responsibility. Japan was defeated, but it was not to be dismantled. It was to be stabilized. One of the earliest and clearest directives issued under SCAP concerned public health. Disease, not resistance, was identified as the most immediate threat. Crowded cities, contaminated water, malnutrition, and untreated wounds created ideal conditions for epidemics. The experience of Europe had already demonstrated how quickly typhus and cholera could undermine military control. Japan, with its dense population and shattered infrastructure, posed an even greater risk. As American occupation forces moved into cities and towns, medical units followed closely behind. U.S. Army doctors, Navy surgeons, nurses, and corpsmen were assigned to inspect hospitals, reopen clinics, and assess sanitation. Mobile medical teams were dispatched into devastated urban neighborhoods and rural areas where no functioning care remained. Their mission was clear: prevent disease, restore basic treatment, and keep the population alive. But the reception they encountered was not gratitude. In many hospitals, Japanese civilians refused to make eye contact. Some would not speak. Others physically recoiled when American doctors approached. Nurses stepped forward instead, acting as buffers between patients and foreigners. Interpreters quickly became essential, not only for language, but for trust. American medical personnel were often struck by the condition of the patients. Burns had gone untreated for weeks. Wounds were infected beyond what most battlefield surgeons had seen. Children arrived with severe malnutrition, their bodies too weak to respond normally to illness. In Hiroshima and Nagasaki, survivors presented symptoms no one fully understood: hair loss, bleeding gums, fatigue so deep it resembled surrender itself. American doctors documented everything. They worked methodically, clinically, and with restraint. Treatment began with triage: who could be saved, who could be stabilized, and who was already beyond help. Penicillin was administered sparingly, but decisively. Dressings were changed. Instruments were sterilized. For many Japanese patients, it was the first time since the war began that proper medical procedure had been followed. The shock came not from what was done, but from how it was done. There were no interrogations, no shouted commands, no violence. Doctors spoke softly, even when patients could not understand their words. They washed their hands before treatment. They bowed slightly, awkwardly, mirroring gestures they had observed. Some removed their helmets indoors out of instinctive respect. Japanese medical staff watched closely. Many had expected dismissal or humiliation. Instead, they were asked to assist. American doctors shared supplies. They explained procedures through translators. In some cases, they deferred to Japanese physicians who knew local conditions better. This quiet cooperation formed one of the earliest bridges between occupier and occupied. Outside hospitals, the occupation medical effort expanded rapidly. Vaccination campaigns were launched to prevent cholera and smallpox. Water purification systems were repaired. Sanitation inspections became routine. In Tokyo alone, thousands of civilians received medical attention from American personnel in the first weeks after surrender. For civilians, the experience was disorienting. The uniforms were those of the enemy. The language was foreign. But the hands that cleaned wounds and eased pain did not match the stories they had been told. Rumors began to change. Fear softened into confusion. Confusion, slowly, into disbelief. This was not forgiveness, nor was it trust, but it was the first moment when expectation and reality no longer aligned. As American doctors continued their work, each treated wound became more than a medical act. It became a quiet contradiction of wartime belief, one patient at a time. And within those small, human encounters, a larger transformation was beginning to take shape. For Japanese civilians, the first encounter with American doctors unfolded inside a psychological landscape shaped by years of fear. From the opening months of the Pacific War, propaganda had worked relentlessly to define the enemy. Americans were depicted as violent, morally corrupt, and incapable of restraint. Leaflets, radio broadcasts, and school lessons reinforced a single message. Capture meant suffering, and contact meant degradation. By 1945, this image was deeply internalized, particularly among women, children, and the elderly. When American medical personnel entered civilian spaces, the reaction was instinctive. Patients tensed, bodies stiffened. Some refused treatment outright. Others accepted care, but remained rigid, staring at the ceiling, expecting pain to follow kindness. What unsettled them most was the absence of cruelty. Doctors did not rush. They did not shout. They did not treat Japanese patients as defeated enemies. Instead, they followed a routine that felt almost ceremonial, cleaning wounds carefully, speaking through interpreters, recording notes. This calm contradicted everything civilians had been conditioned to expect. Shock did not arrive as relief. It arrived as dissonance. Many patients later recalled the same moment, realizing they were being treated with the same care given to American soldiers. There was no hierarchy of worth at the bedside. Burns were burns. Infection was infection. Pain was pain. This realization spread quietly. People talked. Families compared experiences. Fear did not vanish, but it began to fracture. The conditions American doctors faced were among the most severe civilian medical crises of the 20th century. Japanese hospitals lacked basic supplies. Sterile environments were rare. Surgical tools were reused without proper cleaning. Anesthesia was often unavailable. Wounds that would have been survivable in peacetime had turned fatal simply through neglect and infection. Burn injuries dominated admissions. Firebombing had inflicted deep, irregular burns across entire neighborhoods. Victims arrived weeks later with skin fused to clothing, infections advancing unchecked. Treatment required debridement, painful, precise removal of dead tissue. Even with American supplies, success was uncertain. In Hiroshima and Nagasaki, the situation was worse. Radiation sickness presented symptoms that baffled even experienced physicians. Patients deteriorated without visible cause. Blood counts collapsed. Hair loss, internal bleeding, and overwhelming fatigue appeared days or weeks after initial survival. Doctors could only observe, document, and alleviate symptoms where possible. American medical teams worked within strict limits. Penicillin was scarce. Blood transfusions were difficult to organize. Nutrition was inadequate. Treatment was often a matter of slowing decline rather than reversing it. These constraints forced doctors into decisions that weighed probability, not hope. And yet, within these limitations, care remained deliberate. For American doctors, this assignment represented a profound shift in identity. Most had trained for battlefield medicine, rapid triage under fire, amputations performed in minutes, lives measured in seconds. Now, they worked in silence, among civilians who spoke another language and wore the scars of a war their own nation had just concluded with overwhelming force. Some doctors had served in combat against Japan. Others had lost friends in the Pacific. They arrived carrying private memories that did not disappear when they entered hospitals. But the medical oath did not change. Patients were not interrogated. Backgrounds were irrelevant. Treatment followed diagnosis alone. Many doctors later wrote that this discipline, this insistence on professional neutrality, was the only way to reconcile their roles as both soldiers and healers. The emotional distance was not coldness. It was control. Through routine, through procedure, American doctors created a space where war was temporarily suspended. Within that space, enemy and ally no longer existed, only patient and physician. Japanese civilians sensed this. They noticed that doctors did not linger on uniforms, that questions were medical, not political, that pain relief was given without condition. These details accumulated into something quietly powerful. By the time a bandage was secured or an infection stabilized, the shock had already occurred, not as a dramatic revelation, but as a subtle understanding that the war had ended differently than expected. That understanding would soon expand beyond individual bedsides, shaped not only by personal encounters, but by policy, leadership, and the broader aims of occupation. The presence of American doctors in Japanese civilian hospitals was not accidental. It was the product of deliberate occupation policy. Under SCAP, public health was framed as a foundation of stability. General MacArthur and his advisors understood that military victory alone could not secure control. A population weakened by disease, hunger, and untreated injury would invite unrest and undermine governance. Medical care was therefore treated as both humanitarian necessity and strategic imperative. Orders issued to occupation forces emphasized restraint, professionalism, and non-retaliatory conduct. Medical units were instructed to operate independently of military policing. Their visibility was intentional. Healing, not intimidation, was meant to define the earliest civilian encounters. This approach marked a departure from previous occupations in history. Rather than relying on coercion, the occupation sought legitimacy through function. Clinics reopening, vaccinations administered, water purified. These were tangible signals that the new authority intended continuity, not annihilation. Doctors became the most immediate representatives of that intent. For Japanese doctors and nurses, the arrival of American medical teams was deeply unsettling. Many had endured years of extreme scarcity. They had watched patients die for lack of bandages, anesthetic, or antibiotics. Some had been forced to make impossible choices under wartime rationing. Others carried guilt for decisions made in desperation. Initial encounters with American counterparts were cautious. There was professional pride at stake. Japanese medicine had a long, respected tradition. To accept foreign oversight, especially from a former enemy, risked humiliation. Yet reality left little choice. American doctors did not dismiss them. Instead, cooperation developed through necessity. Supplies were shared. Procedures were discussed. Japanese staff provided cultural context, while Americans provided materials and logistical support. Gradually, the hierarchy softened into collaboration. This partnership had quiet consequences. Japanese doctors observed techniques and treatments unavailable during the war. Penicillin became a symbol, not of American superiority, but of lost opportunity. The war had not only destroyed cities, it had isolated Japan from medical progress. For some, this realization was more painful than defeat. The treatment of Japanese civilians by American doctors exposed a rarely acknowledged dimension of modern warfare: the separation between destruction and care. The same nation that had leveled cities now sent physicians to treat the wounded. This contradiction was not resolved or explained. It existed as fact. For civilians, this did not erase grief or loss. Families were still gone. Homes still burned. The atomic shadow still lingered. Medical care did not absolve the past, but it altered the present. The presence of doctors introduced a new narrative, one in which war ended not with vengeance, but with obligation. Not moral reconciliation, but responsibility to stabilize what had been broken. History often records surrender ceremonies and treaties. It rarely records bandage changes, vaccinations, or wound cleaning. Yet these acts shaped memory just as powerfully. For many Japanese civilians, the moment they realized American doctors would not harm them marked the true end of the war. Not August 15th, but the day pain was treated without judgment. This moral ambiguity, this uneasy coexistence of destruction and compassion, would define how the occupation was remembered. And it would soon be tested in moments where care moved beyond individual treatment and into collective experience. Those moments would arrive in the hospitals and clinics most deeply scarred by the war, where suffering was greatest, and where expectations would be challenged most intensely. The turning point did not arrive with an announcement. It arrived through accumulation. In Hiroshima, the medical crisis had reached a scale unlike anything American doctors had encountered. Weeks after the blast, survivors continued to arrive, some walking, some carried, many collapsing at the entrance to makeshift clinics. The city's remaining hospitals were shells. Walls stood without roofs. Corridors ended in open sky. What passed for wards were rows of bodies laid out beneath tarps. American medical teams entered these spaces cautiously. There was no precedent for what they were about to witness. Burn victims with no external injuries suddenly deteriorated. Patients who seemed stable one day died the next. White blood cell counts dropped to near zero. Hair loss spread like an omen. Doctors recorded symptoms meticulously, knowing they were confronting something new. But documentation did not slow the work. Children with burns covering half their bodies were cleaned and dressed. Elderly survivors suffering from dehydration were given fluids. Infections were treated where possible. Pain was addressed, even when cure was not. The scale forced a shift from individual shock to collective recognition. Japanese civilians began to see Americans not as isolated figures, but as a sustained presence. Day after day, the same doctors returned. The same nurses changed bandages. The same interpreters learned names. Treatment became routine, not an exception. In Tokyo, similar patterns emerged. Firebomb survivors flooded surviving hospitals. Entire families arrived together, burned in the same raid, sleeping on the same floor. American medical teams established triage stations that operated continuously. Supplies were rationed. Decisions were made quickly. But there was consistency. No patient was turned away because of nationality. No civilian was punished for having once been the enemy. For many Japanese observers, this was the moment disbelief gave way to certainty. The realization spread quietly through wards and waiting areas. The Americans were not here to harm the wounded. They were not selecting who deserved care. They were simply treating. The shock lay in repetition. One act of kindness could be dismissed as anomaly. Hundreds could not. Japanese nurses began stepping aside instead of standing between patients and doctors. Families stopped hovering defensively. Some civilians began bowing, not deeply, not formally, but instinctively, as tension released from their bodies. American doctors noticed the change. Patients spoke more. Children cried less when approached. Eye contact increased. Silence softened. Trust did not emerge as gratitude. It emerged as exhaustion giving way to relief. This was not reconciliation. It was recognition. Recognition that the war had crossed into something else. That survival now depended not on resistance, but on cooperation. That the uniform in a room did not determine the intention of the hands working beneath it. In Hiroshima and Nagasaki, the work carried an additional weight. Doctors understood that many patients would not survive regardless of care. They treated knowing outcomes were uncertain. Yet they continued because withdrawal would have confirmed fear. Presence mattered as much as medicine. By late autumn 1945, the pattern was undeniable. Where American doctors worked consistently, panic receded. Rumors changed tone. Stories passed from family to family, no longer warned of violence, but of treatment, of wounds cleaned gently, of pain eased, of children spared. The shock that once paralyzed civilians had transformed into something quieter, more durable. Expectation had been defeated, not by force, but by persistence. And as that realization settled into daily life, it reshaped the relationship between occupier and occupied in ways no policy document could have predicted. What began as emergency care was becoming something larger, a turning point where fears ceased to define the encounter. As autumn deepened into winter, the transformation became visible not in declarations, but in behavior. Hospitals that had once felt like contested ground began to function as shared spaces. American doctors moved through wards without escorts. Japanese nurses no longer flinched when orders were given in accented Japanese through interpreters. Patients waited, sometimes for hours, without panic, trusting that care would come. The most powerful change was subtle. Japanese civilians began to arrive voluntarily. In the weeks immediately after surrender, many wounded had been brought only because families had no alternative. Now, people came on their own. Burn victims from outlying districts traveled into cities. Parents carried children suffering from fever or malnutrition. Elderly civilians presented themselves for treatment rather than hiding their injuries at home. This shift marked the true turning point. Fear had not been argued away. It had been worn down. American doctors recognized the moment as well. Medical logs noted rising civilian attendance. Clinics expanded hours. Mobile teams increased outreach into neighborhoods once avoided. Treatment became less reactive and more systematic. In Hiroshima and Nagasaki, the emotional weight of care intensified. Doctors confronted the limits of medicine daily. Radiation sickness continued to claim lives months after exposure. Survivors who had seemed to recover suddenly collapsed. There was frustration, helplessness, and quiet grief among medical staff who could not explain what they saw. Yet withdrawal was never considered. Instead, American teams leaned into documentation and presence. Blood samples were analyzed. Case histories were compiled. Patterns were shared among units. These efforts would later form the foundation of long-term medical research. But in 1945, they served a simpler purpose: to show that the suffering was being taken seriously. Japanese civilians noticed. They noticed when doctors stayed late. They noticed when bodies were handled with care. They noticed when death was recorded, not ignored. In Tokyo, the same recognition took root. Firebomb survivors who had once avoided occupation personnel now interacted openly. Some spoke through interpreters about the night raids. Others said nothing, allowing treatment to speak for itself. American doctors listened, not as interrogators, but as witnesses. Trust did not produce affection. It produced normalcy. By early 1946, American medical care was no longer shocking. It was expected. That expectation carried profound implications. When disease outbreaks threatened, civilians complied with vaccinations. When sanitation measures were introduced, neighborhoods cooperated. Public health directives, once feared as control mechanisms, were accepted as protection. The occupation had crossed an invisible threshold. Medicine had succeeded where force alone could not. It had created legitimacy not through ideology, but through reliability. Care that arrived consistently became authority that did not need to announce itself. For American doctors, the realization was sobering. They had not come to change hearts. They had come to prevent epidemics and treat wounds. Yet their work had become one of the occupation's most effective stabilizing forces. Without speeches, without banners, they had reshaped civilian perception of the enemy. For Japanese civilians, the moment crystallized differently. The shock was no longer that Americans treated their wounds. The shock was that they kept doing it, day after day, patient after patient, without exception. That repetition rewrote memory. The war's violence could not be undone, but its final chapter was being written not in tribunals or parades, but in clinics where former enemies stood side by side, bound by necessity and care. As winter passed, the immediate crisis eased. Disease rates declined. Hospitals regained structure. The occupation stabilized. What remained was consequence. The treatment of Japanese civilians by American doctors had shifted the emotional ground beneath post-war Japan, setting in motion effects that would reach far beyond the hospital walls. Those effects would define the aftermath. By the spring of 1946, the immediate medical emergency that had defined the early months of occupation began to subside. Disease outbreaks feared by Allied planners did not materialize at catastrophic levels. Cholera and typhoid were contained. Smallpox vaccinations reached deep into urban and rural populations. Dysentery rates declined as water purification systems were repaired and sanitation standards enforced. These outcomes were not accidental. They reflected the cumulative effect of thousands of medical interventions carried out quietly and consistently. Clinics reopened under joint supervision. Mobile medical teams extended reach into areas once isolated by destruction. Japanese hospitals, though still under-resourced, began functioning with predictable routines. For Japanese civilians, this stabilization altered daily life. Medical care, once an unpredictable luxury, became accessible again. Families no longer delayed treatment out of fear. Mothers brought children for vaccinations. Elderly patients sought care for chronic conditions rather than waiting until crisis struck. The psychological shift was just as significant as the medical one. American uniforms no longer triggered automatic panic in clinical settings. Doctors were recognized by role rather than nationality. While resentment and grief persisted, inevitable after years of war, they no longer dominated every interaction. This change had immediate strategic consequences. Occupation authorities found public health directives easier to implement. Compliance with quarantine measures improved. Civilians cooperated with inspections of water sources and food distribution centers. The stability of the population allowed broader reforms to proceed without violent resistance. In Hiroshima and Nagasaki, the aftermath took a different form. Survivors continued to suffer long-term effects that medicine could not yet explain or cure. American doctors remained present, documenting symptoms and patterns with increasing rigor. Their work laid the groundwork for later institutions, including the Atomic Bomb Casualty Commission, which would study radiation effects in the years to come. For survivors, this attention carried mixed meaning. It did not heal the past, but it acknowledged it. Patients were no longer invisible casualties of history. Their suffering was recorded, measured, and treated with seriousness. This recognition mattered deeply in a society grappling with defeat and loss. The medical relationship forged in these months also reshaped professional norms. Japanese doctors gained access to new treatments and techniques. Penicillin, once scarce, became more widely available. Infection control standards improved. Training exchanges began under occupation oversight, integrating Japanese medicine into post-war global practices. These developments did not erase inequality or hardship. Food shortages persisted. Housing remained scarce. Many hospitals still lacked resources. But the sense of abandonment that had characterized the final year of war receded. American doctors, once symbols of fear, became associated with continuity. Their presence signaled that the worst uncertainty had passed. This transformation extended beyond hospitals. Stories circulated through communities. Not dramatic tales, but practical ones. How a wound was treated, how a fever was reduced, how a child survived. These accounts spread faster than official proclamations, shaping civilian perception at a grassroots level. The occupation's success in stabilizing Japan owed much to these unrecorded narratives. Medical care did not reconcile nations. It did not erase memory, but it created space for survival. And in that space, Japan began the long process of rebuilding, physically, socially, psychologically. Yet the consequences of these early medical encounters did not end with stabilization. Their influence would extend into policy, research, and the evolving relationship between former enemies. Those longer-term effects would define the deeper aftermath still unfolding. As the occupation progressed, the early medical encounters between American doctors and Japanese civilians began to shape outcomes far beyond emergency care. Public trust, never complete, never uniform, had reached a level sufficient for governance. This trust was not rooted in ideology or persuasion, but in experience. Civilians judged the occupation by what it did in moments of vulnerability, and medicine had been present in those moments. This credibility influenced broader reforms. Health policy initiatives introduced under SCAP encountered less resistance than anticipated. Maternal and child health programs expanded. Nutritional interventions were accepted in schools and clinics. Disease surveillance systems, once viewed with suspicion, became part of daily administration. The medical dimension of occupation also left an institutional legacy. In Hiroshima and Nagasaki, American documentation of radiation-related illness evolved into long-term research efforts. The Atomic Bomb Casualty Commission, established in 1947, formalized studies that had begun at the bedside. While later criticized for its limitations, its origins lay in the early decision not to abandon survivors once immediate crisis passed. For Japanese civilians, this continuity mattered. It signaled that their suffering was not a temporary concern, nor a footnote to victory. It was a reality that demanded sustained attention. Even when cure was impossible, acknowledgement remained. The impact on U.S. Japan relations was subtle but lasting. Medical care did not erase the memory of destruction, nor did it produce instant reconciliation, but it moderated the emotional environment in which political and economic reconstruction unfolded. The occupation was remembered not solely as control, but as management of survival. For American medical personnel, the experience reshaped professional identity. Many returned home carrying complex reflections. They had treated former enemies who resembled their own families in vulnerability. They had confronted the moral contradiction of healing in the shadow of unprecedented destruction. Some later wrote that the occupation challenged their understanding of victory itself. These personal reckonings rarely entered official histories. Yet they influenced how medicine and military service intersected in the post-war era. For Japanese medical professionals, collaboration under occupation accelerated reintegration into global medical networks. Access to modern pharmaceuticals, research methods, and public health frameworks helped rebuild a profession isolated by years of war. The long-term effect was not dependency, but transformation. Japan's post-war health system would evolve rapidly, shaped in part by lessons learned during these early months. Lessons forged in crisis, cooperation, and quiet necessity. At the civilian level, memory settled unevenly. Some remembered American doctors with gratitude. Others remembered them with neutrality. Many held conflicting emotions, relief interwoven with grief. These responses reflected the complexity of the experience itself. What remained consistent was recognition. Recognition that in the immediate aftermath of defeat, when fear was at its sharpest, care arrived instead of punishment. That expectation had been overturned at the most human level. As years passed and occupation gave way to sovereignty, the medical encounters of 1945 to 1946 receded from public discourse. They were not celebrated. They were not mythologized. But they endured quietly, in personal memory, in professional practice, and in the foundation of post-war stability. These were not moments of spectacle. They were moments of function. And in history, function often leaves the deepest mark. That understanding brings us to the final reflection, where meaning emerges not from drama, but from consequence. War is most often remembered through its violence, through the moment of impact, through destruction measured in numbers, through victory and defeat declared in formal terms. Yet history is also shaped in quieter spaces, where the war does not announce itself, but lingers in the body. In the months after Japan's surrender, American doctors entered those spaces. They did not arrive to rewrite the past or erase suffering. They arrived because untreated wounds, unchecked disease, and human collapse threatened to extend the war beyond its official end. What unfolded was not reconciliation, but interruption. An interruption of fear. An interruption of expectation. An interruption of the belief that enemies could only harm. Japanese civilians had been taught to anticipate brutality. Instead, they encountered procedure. Hands that cleaned wounds. Voices that remained calm. Care delivered repeatedly, without spectacle or condition. This did not absolve the destruction that preceded it. Cities remained burned. Families remained broken. The atomic shadow did not lift. But something essential changed. The war stopped defining every human interaction. Medicine created a narrow corridor where identity dissolved into necessity. In that corridor, the defeated were not judged, and the victorious were not exalted. There was only injury and response, suffering and attention. For the occupation, this mattered more than any proclamation. Stability was not achieved through force alone, but through reliability. Care that returned every morning became authority that did not need to threaten. For history, the significance lies in contrast. The same conflict that produced unprecedented destruction also produced moments where restraint, professionalism, and obligation prevailed. These moments did not undo the war, but they shaped how it ended. When Japanese civilians realized that American doctors would treat their wounds, the shock was profound not because it was kind, but because it was consistent. In that consistency, fear lost its hold. And in that quiet loss, a defeated nation began to survive, not through surrender alone, but through care that arrived when it was least expected.